We're going to move into the general Q&A now. There were over 160 questions ahead of the conference, and we received quite a bit while the conference is going on. Um, all of the physicians who are still here are welcome to turn on their cameras, turn on their microphones, and we can move into a general Q&A. Dr. Callen, while we're waiting for that, there's two questions about access to care specifically that we talked about that came up. So maybe we can start there. Um, One from a patient says, is there anything that we can do as patients to help with the insurance codes problem that you're having? How to get better coding for the procedures that Dr. Madhavan, that everyone are performing?
I wish I knew a very specific answer to that because if I did, I think I would be trying to advocate it for us now. I think that engaging health policy experts and in other sort of this has happened in other diseases where we've needed to refine our sort of medical coding and medical language around other disease states. I'm curious if any of my other colleagues have ideas on ways that we could begin approaching this or advocating for this in general, but I don't have a great answer for it.
I'm with you, Andy. I think it's a really hard thing. I mean, one of the things we don't learn in med school is how to deal with this kind of stuff, right? So I have generally relied on experts, and that's where folks like people in the Spinal CF like Leak Foundation are so helpful. But it's really tough.
Thank you. I think patients, really want to contribute in any way they can to making it easier for you, which therefore obviously makes it easy for us too. But the systems are often really complex, and I know they're quite different in different countries. Dr. Beck, I'm curious if this comment that we made about the sort of coding systems in the States with the ICD-10 codes, is that something that exists in your system, or is it quite different there?
No, absolutely. That's a huge problem. And I think the lack of centers that take care of spinal CSF and pediatric patients is truly related to this. And I know many centers who tried to start a CSF leak service, but they failed because, as Dr. Callen has said, it's to get the same amount of refund for a standard myelogram that takes probably 20 minutes versus one that's the chairman of the neurology department and radiology department needs to do takes 1.5 hours and reread the scans and so on. So it takes too much time for many busy services to start a CSF leak center, despite there's this huge will. And I really do not understand this because not the caregivers, uh, the funders of the system, they should have an interest in pushing this because many of the affected patients are losing their jobs and are a huge socioeconomic loss for the society, and this hasn't really been understood, I think. And this conference is a start, and we need to push harder to convince the funders to fund this type of clinical care as well as research better. It's a huge problem, and I fully agree.
I think that, yeah, one thing I'll just add to that, I completely agree, Jürgen. And, we've kind of talked about the sort of touchy-feely part of like, we can learn from each other. But I have learned so much from my patients who, I am surrounded by doctors all day. I'm a doctor. This is all I think about. I'm embarrassingly ignorant of things about economic policy, healthcare systems related issues. And I have patients who I've approached me after this conference where like, actually, that's my thing. That's my job. I could help with learn, with this or that. And this is the sort of tangible teamwork that we can create and sort of foster together. Is that we are very siloed in medicine and we love just focusing on this one thing, but we need broader perspectives, especially for people suffering from the condition who have that expertise that we don't, that could help us together sort of advocate and push this field forward.
I think that there's a lot of patients that would love that as well. Just from a practical perspective, you all see patients with multiple different, comorbidities. For example, a connective tissue disorder or mast cell disorder. I asked Dr. Callen earlier when we were prepping for our conversation, would he be amenable to a patient, let's say, bringing sort of a PDF from a specialist to help kind of inform some of the care that he's doing. And on that level, I think that's something that the patients aren't really sure where to navigate themselves, not wanting to be too pushy, but having these other comorbidities that exist. I'm curious with the other physicians, Dr. Madhavan, you're doing scans for people. Let's say they have contrast allergies. Are you open to those sorts of not an official peer-to-peer, but if a patient was to say bring you like a PDF that their other doctor presented to them for this sort of procedure?
Yeah, I certainly am. I think it's super helpful because a lot of times we don't know their perspective going in. Like we don't know what they've been told. We don't know what they know about the procedure, and things like that. So I'm very open to that. I mean, I think what I could anticipate they would run into, would in some cases is somebody might be really having a really busy day, and that could be what could prevent them from doing stuff like that. But I never think it hurts to try. I mean, I think it's a good idea to come, like you said, with as much information as you can, and like I don't think you should ever have fear that your doctor's not going to be receptive to it because if they're not, then it's kind of on them, you know.
Fair enough.
Uh,
Thank you.
I I think that, you do if you do enough of this work, you begin to be humbled by how much you don't know. I tell my patients, I'm not an expert on mast cell activation syndrome. I'm not an expert on connective tissue disorders in general. And it's easy, I think, as a physician, we like being experts on things, and we don't like saying we don't know things. And so it's easy to say, well, if I don't know anything about that, then that must be something that is not real, or what have you. But all it takes is taking care of enough of these patients to see somebody, have a severe skin reaction to just chloroprep on their skin, to know this person has more of a hypersensitivity than I realized. There's something to this that I don't fully understand, and that medical science doesn't fully understand. It's this repeated pattern of my patients having these issues, these systemic issues. There's something here that we don't fully yet grasp. And so I think it's just always important. As soon as we start feeling too confident in what's going on, I think we've started to sort of fail ourselves and our patients when it comes to those issues.
I was one of those patients, right? I didn't know I had MCAS until I went into anaphylaxis on the table during my fourth round of patching. But I had symptoms of it for many years. I had all these weird reactions or all these weird things happening in my body that I just never thought to connect. But it was reactions during the procedure that sort of precipitated the need for that diagnosis. And I think some patients are finding similar where they have these underlying issues that they didn't know about, and during the procedures, there's some sort of reaction that's causing them to investigate further. So it's sort of happening in tandem. Um, for one last question on that front, there's a question we got submitted ahead of time about if a patient does have a comorbidity such as MCAS, and I don't know if Dr. Shabink is still here, but I'm sure he has thoughts on this too. If their body rejects a dural graft or may reject a dural graft, is there a sort of better graft or a graft that has more tolerance in that patient population that versus another, or a type of repair that is, let's say, more successful to patients that may have those immune system disorders? I don't know if Dr. Beck, you have a thought on that question.
There is clearly one thought that is using PRF more often. PRF is platelet-rich fibrin, which is just we withdraw blood from the patient and centrifuge it in the OR. It takes like 10 minutes or so during the procedure. And it depends on how we handle the vials. We can make fluid PRF or rigid PRF formulations. And this is only from the patient. There is no additive, no nothing. And this, I think, is at least from in theory, probably a good way for MCAS patients, but there are no data yet out. So, but this is clearly something I would try.
Do you find that reactions to Tequasil are less than, let's say, a bovine graft, for example, or is that not something you've sort of seen a pattern for?
No pattern. Sorry, no
No,
pattern.
no, no problem. That's fine.
Reactions to both, but I have to admit I haven't recognized a specific pattern for that. Sorry.
No, don't be sorry. We're just happy to have these conversations with you. Dr. Callen, are there any efforts in the United States to do something of the nature that Dr. Beck is saying, of sort of that that centrifuge of our own fibrin as an opportunity to sort of sidestep the hyperactivity for some people?
I've heard of some physicians doing things similar to that. I know also, just speaking from personal experience, what we're doing here in Colorado, we're working closely with some of our PhD collaborators who are working on hydrogel-based dural substitutes, which theoretically have less immunogenicity in terms of reaction of it's still a fluid material, but the sort of nature of hydrogels could theoretically be less inflammatory or sort of immunogenic, so to speak. The like one thing I learned from speaking to more surgeons and working in this domain is how frustrated they are, at least in the United States, with the lack of or like the options for dural graft or dural substitute. They all have something good about them and then something bad about them, and then you have to choose, which is the one that you're going to use for any given procedure or surgery. So I think there's definitely more work to be done, and I think an enterprising medical device company could really make a big difference here by helping in this way.
Thank you. Um, we've talked about normal imaging for today in many different sessions, and I'm wondering, as patients are wondering, what regardless of the type of leak, is there a theory as to why this image appears normal? We know sometimes in chronic cases it resolves into a more normal state for leaks that are already appearing as normal at onset. Is this because there's potentially underlying higher CSF pressure or volume, or is there a known mechanism for why imaging would appear normal versus not?
AJ, you want to take this one?
Sure. Yeah. I mean, I'm not specifically that I know of. I think you're right that many times it seems to happen in patients who've had a leak for a longer period of time, but not always. I've also seen it happen in patients with relatively recent onset symptoms. I think it probably has something to do with just a normal compensatory mechanism. Jürgen talked about that editorial from Jeremy, and I think that highlighted a lot of good points about how there's some sort of compensation with the way the structure, the function of the dura that probably causes the findings of intracranial hypotension to improve. And the other side of it too, I think you're mainly referring to brain MRI findings, but more and more, like I've started to appreciate even like spine MRI findings in patients with dural leaks can normalize or be normal too. So this whole concept of just being, brain and spine being normal, I think is really important. Um, yeah.
Thank you. Um, I think we're all realizing in all these conference acts, there's so much. It's a nascent field. There's so much research that happens, and there's sort of more research, obviously, that we are excited to see done. Speaking of, um, one of the questions we received is there a known association between menstrual symptoms and hormone fluctuations that modulate CSF? There were studies this year that came out about how the menstrual cycle affects CSF production and flow, and that of spinal CSF leak symptoms. And the question was, are there any studies planned for spinal CSF leak physicians, especially given that the condition affects women a lot of the time?
I am woefully uninformed on this specific topic, and I think this is just points to another reason why we need that better multidisciplinary collaboration so we can have, for example, endocrinologists weigh in on this topic and give their opinion about this. I mean, I know that menstrual cycles, hormonal fluctuations can definitely modulate other headache disorders, and contrary to what doctors love to believe, which is that every patient just has one diagnosis, you can have more than one thing going on, right? One thing can modulate another. People can have spinal CSF leak and something else too, and those things can be an interplay and each make each other worse, for example. But I don't have a good answer about or really sort of any nuanced insight into that specific question.
Thank you. Throughout the conference today, there were several instances and questions about timing and how timing for treatment matters in general. Patients often ask about the long-term effects of a spinal CSF leak that goes untreated. We've seen Dr. Shavink's presentations about superficial siderosis and sort of other complications thereof. But one question that is asked often and was prior to this conference was whether patients can incur TBI-like injuries if there's like a lower volume of CSF that's cushioning the brain. There is an overlap in the two symptoms, and patients are wondering, does it actually damage the brain in the way a TBI is seeing people have damage to their brain?
I'm getting a more and more strong opinion on that, and I think really a CSF leak needs to be repaired. And that what we are speaking of right now, superficial siderosis or the atrophy of the muscles, is just the pinnacle, the tip of the iceberg. I do not believe that a spinal CSF leak is good for your brain or for your spinal cord. And there's more and more data that we have. This is a very controversial term, but this kind of spinal dementia, a very exaggerated term, brain fog, on the other hand, is real and we can measure it. And just the latest data from Freiburg is that we only needed 40 patients or so and did simple tests before surgery and 2 days after surgery, still with anesthesia in place, and they all were dramatically better on cognition tests and set course performing just simple tests. So there's a lot going on, and the spinal CSF leak is not healthy for your brain. And I haven't thought about this, but I do even like the comparison with traumatic brain injury. I think it is also, um, again, the tip of the iceberg is the behavioral variant frontotemporal dementia, where the brain really sags down immensely. But there's also a tiny shift in between the brain when we measure it in we call it tectonic shifting. So the mesotemporal structures are displaced before and after leak closure. And the mesotemporal structures are clearly related to cognition and to memory. So I do really believe spinal CSF leak needs to be closed.
And
Thank
you're
you.
gonna oh, sorry, Jody. I just had a follow-up question for Dr. Beck. I was really impressed and interested in what you're talking about in Amsterdam about your group's work and just sort of your comments about subdural hematomas and thinking about them and how many patients are misdiagnosed in terms of having subdural hematomas. And if we just kind of go looking at all people who have subdural hematomas, what percentage of them have spinal CSF leak? I feel like it's sort of tangentially related to the question, in that this is a thing that we think about as trauma, right? Or traumatically caused, and then also can caused by spinal CSF leak. Maybe you could just tell us one or two things about that.
Thanks for this question. Of course, I love to talk about that. So we started we started a projective study, prospective study, even registered, that we do all patients with chronic subdural hematomas do an MRI and a myelogram with a suspicion for a CSF leak. Even 85 years old with a known fall. And currently, I mean, the numbers are not official yet, but it's not a blinded study, so I can talk about it. It's prospective, but not blinded. And currently, the numbers are in the range of 10, 12, 15% of this. This is the most often, one of the most often happening diagnosis in any neurosurgical center around the world is chronic subdural hematomas. And if we really do detect spinal CSF leaks, and we only do one shot, not all the sophisticated stuff in elective cases, and if one shot, 1 myelogram is enough to detect 10 to 15%, this is changing the story. And we are a little bit afraid of our own results, because what next? Shall we really scan all patients with chronic subdurals? It's a big issue. And this also underscores only that we really do need a biomarker for CSF leaks. We do need a biomarker. Apart from imaging, something that we find in the blood, something that we find in the CSF. And this is probably the next big trial we should do. And talking about trials, this is funded by my department and by the department of Horst Urbach, the radiologist, and Niklas Lützen and Charlotte Sander, and we do not get funding for this. Imagine, we complained about education and people getting to know CSF leaks. Imagine that CSF leaks have the same incidence like multiple sclerosis, which is a multi-billion-dollar industry, and we do not get funding for a single study. So there is really, let's put it in better words, there's way of improvement. Yeah.
Thank you.
Thanks, Andrew.
This is also a question for Dr. Beck, specific to the neomembranes that you have talked about today and otherwise. Given the presence of angiogenesis of those neomembranes, patients are wondering, can ongoing CSF leakage damage the integrity of the dura surrounding the leak? Like, is it common that around the leak it's sort of translucent or thin due to CSF being outside of where it's supposed to be? Does it have a corrosive component?
Good question. No, I think it's the other way around, but this only from my surgical experience. I think these new membranes form and try to strengthen the dura. They don't do it, but it's not a corrosive of the dura, a corrosiveness of the dura. It's just an additional layer. So I think, from my perspective, you don't have to be afraid of an additional corrosion of the healthy dura. It's just the spread of um, a faulty attempt of the body to heal it, like in some autoimmune arthritis. It's overshooting. It's not corroding the dura. It's just an additional layer that is too much, and it is usually 1.5 levels above and below of the leak, and then it fades out.
Thank you. A question for just generally about CSF lymphatic fistulas. I think first of all, if for those patients who aren't aware, if you could first just explain what they are versus uh, CBFs, and just explain what makes them different to CSF venous fistulas, as they've been discussed in some of the literature in today as well, and then not all patients are familiar with that type of leak.
Yeah, I mean, so I can start with this, and then AJ, if you want to jump in. It's a much more rarely described phenomenon. It was, yeah, I believe it was Dr. Leitzen and colleagues who first described a case report of it. We've also seen when and published on a person who had a CSF lymphatic fistula very close to her skull base that resulted in a syndrome of intracranial hypertension. And one thing that I've observed, and I've spoken to my colleagues in Switzerland and Germany about this, is I've had a couple cases where I've had a patient with a dural tear, a type 1 leak, very sort of bread and butter. And on the delayed myelogram, I've seen uptake of the extradural contrast into the thoracic duct, into the lymphatics. So this is not necessarily a primary CSF lymphatic fistula or leak, but it then makes me wonder, if this could be naturally resorbed into the lymphatics via the epidural space, and there's a conduit between the two, are we potentially missing some leaks that are potentially, in some way secondary CSF to lymphatic fistulas in that way? I do think, like with the CSF venous fistula when it was first described, it was, oh, this is this incredibly rare thing. We're never going to see this, but maybe we just don't have the tools yet to really see it. And perhaps it's not super common, but I think that it certainly is out there, and I think deserves attention.
Yeah, interesting points, Andy. I agree with all that. I think that the one thing I'd add, that there's like kind of two, in my mind, two different distinct types of this. So the Dr. Lutzen had this nice, interesting case of a direct CSF lymphatic fistula. So that's kind of analogous to a CSF venous fistula, where it's going directly from the spinal CSF space into the lymphatics. And then there's a different subset that's been described, which are like related to congenital lymphatic malformations. So these are things that you're born with, and they just happen to occur close to the spinal canal, and that results in CSF leakage. Both of them, I think, are relatively uncommon, but I completely agree with Andy. There's a strong possibility that we just don't have the tools to recognize a lot of these. So it's an interesting topic.
Many of these are interesting and sort of moving quickly. It's really exciting as a patient to be a part of a conference like this, where I get to hear about the newest research and have the honor of asking questions too. One of the questions we received is about rebound intracranial hypertension. Um, Basically, a question of different physicians have different opinions. Is it best to let your body recalibrate post-seal by itself, or to use something like Diamox or metazolamide or other medications to basically avoid putting pressure on the newly sealed leak site? And as a patient with a connective tissue disorder, I wonder if that answer would change if someone has EDS or Marfan, or a disorder where their scar tissue may be different to the average patient, for example.
Think, my perspective on RIH has changed a lot. And I think when I talk to patients about it, I sort of frame it in the way that I've thought about it over the years. And I think, when I first started doing this, I think that one way that patients frequently conceptualize RIH is like, it's a good sign. Like there's a leak somewhere. The fluid's been trying to be produced to keep the leak even, and then we closed it, so it's overflowing. So good. I got my rebound hypertension, but the evidence doesn't really suggest that the presence of rebound hypertension is associated with treatment success. We've had several multi-center studies on different kinds of leaks, and none of those have borne out an association between RIH and eventual leak closure. And so I would, based on the evidence we have now, my opinion would be no, I don't want you to experience symptoms of RIH. If at its worst, it could lead to vision loss, which could be permanent, or nausea, vomiting, which that Valsalva could stress our attempted leak repair, and just general discomfort and pain, which I don't want you to be undergoing at all. I think, surgeons, when they do, for example, skull-based surgery, will place a lumbar drain to take the pressure off the site to allow the skull-based leak to potentially heal. There's an interesting question to be raised. I know that Dr. Simi Parikh, who's now at Emory, has suggested that patients preemptively start Diamox before a treatment to sort of lower the pressure in preparation for the patch. I think that's a very interesting question, and one that we should do a study on, a trial on. And I don't really know, but those are sort of my sort of heuristics in terms of how I think about it.
I actually did do that. I think I phrased it as, "Can I pregame my metazolamide before my patch?" And because I went into such severe RIH during my earlier rounds, and I was sealed on my 3rd round of patching, but then it blew, and they said the same, "We don't have data that suggests it's a good or bad idea, but, like, I don't think other than making you feel terrible before your patch, it's sure, give it a try." And I ended up starting it 3 days before and felt absolutely horrible. Um, did that help keep me sealed? I don't know, but, it was something I tried. Um, I'm wondering as well, when we look at the sort of brain side discussion of that pressure, that pulling down for the patients that have those classic symptoms, what structures are sending those pain signals? Or is this a better question sort of for a neurology conference instead? What can you have, is it low CSF tractioning your cranial nerves or other nerves, or are there other mechanisms at play?
Think, I mean, I could provide sort of not a good answer, but a sort of interesting question in response to that question, which is, I thought that maybe a slightly, I wouldn't say overlooked, but there's so many CSF leak papers that come out now. It's hard to keep on top of everyone. But one that I found one of the most fascinating was the one that Duke put out that showed the lack of correlation between symptom severity and burn score. And because what with that the and so just as to summarize, they found that having a more severe brain MRI did not correlate with having more severe symptoms as measured by standardized headache metrics, right? And so this is very interesting because we always hear, oh, it's sagging and traction on meningeal layers, sagging and traction on meningeal layers or cranial nerves, right? But clearly it's not as simple as that. Because if that was the case, the more brain sag you had, the more your symptoms would be. And so I found this resonated with me because I would see people with a brain MRI that looked like horrible, like I would expect them to be in a coma, and they were sitting in front of me talking, and other people with the most subtle venous distension and nothing else who are basically bedbound. And this is something that requires a lot more research to understand what exactly are the pain generating mechanisms for this. And I think there probably is more to it on the venous side than we realize in terms of the sort of nociceptive input from from abnormal venous distension, or the body's attempt at venous distension in the absence of appropriate venous capacitance or compliance. But I don't have a great answer.
And I can't remember, was this from one of your papers? I remember there was either from a lecture or one of your papers, there was something where you were looking at the type of abnormality they have on their brain MRI, correlating that with the symptoms, like whether it's dural enhancement versus brain sagging or something else. Am I thinking?
Yeah. Yeah, no, I mean, so I presented some of our preliminary data in Amsterdam where we were, I mean, and we're still going through that and hopefully gonna get it out soon. But we were looking at, we had found in a previous paper that when you measure the sort of elastance curve of a patient's response and pressure change when you infuse saline, that correlated very much if they had sort of a low elastance or high compliance, meaning I put in 5 cc's of saline, but pressure doesn't go up at all, right? That was more correlated with the presence of the sort of Monroe-Kelly findings on brain MRI, dural thickening, venous engorgement, subdurals. Whereas the opposite it was not correlated with the presence of brain sag. And then we were looking more specifically, not at like, and also then in our CSF-venous fistula sort of clinical paper, the presence of of those findings weakly correlated with the sort of classic phenotype of disease of the Monroe-Kelly type findings. And then in Amsterdam, I mentioned that we were looking at patients who don't get better, right? The leak, as far as we could tell, is resolved. The brain imaging is resolved, but they get no better. And we were finding a very strong correlation between people who did not have venous distension on pre-treatment imaging and not getting better. And so I think there's something. This is why I continue to go back to the venous side of things. The body's of compensatory ability on the venous side to sort of balance this what's going on the CSF side, I think is very important in terms of the symptomatology.
We are at time, but if it's all right with you, if I could ask one more question that we get frequently, which is, do you have patients who have spinal and cranial leaks at the same time? And is there a place that, let's say, treats both? But is that something you've seen in the patients you've treated, that they have both together?
I've not specifically seen it. I think that in general, they're both rare enough that I think we only see them independently. But I don't know if Andy or Jürgen have seen that before. It's an interesting question for sure.
Is it possible to have both together? I guess is the secondary question that some patients ask. Like, you know, if they have, there's been discussion of fluid coming out of your nose, in not ears, but nose with a spinal leak, and some patients are told this is a part of the lymphatic drainage due to the traction on nerves. But for patients who do have, positive beta 2 transferrin tests, but also could they have a spinal leak at the same time, or is there some mechanism that would kind of preempt one or the other? Is the question we received.
I think that most of the time, the drainage from the nose is an autonomic response to the spinal CSF leak, a secondary dysautonomia that occurs in response to that. I would say, I have not really seen that. No, I have not seen a sort of bona fide, like a proven skull-based leak at the same time. I have patients who have had IIH definitely with like skull-based, meningocele or pits, for example. I have a lot of patients who've been told that they have that. And, while trying to keep an open mind, have to ask myself, if this is really going on so much. I mean, look at AJ and our website. Every single week, there's 10 new papers. We're all so excited to share this research. Where is the peer-reviewed research that could show us this? Because if that's going on, if we can make these diagnoses in our patients, and this is a phenomenon that is occurring so frequently, then we need to see it so we can help these people more. And so I am very open to the idea that it's possible. I just hope that people who are making this diagnosis and patients who I eventually see will share that with that information with us in a way that we can all sort of see it and hopefully help people who are suffering from that.
Thank you all for participating in this final Q&A. Dr. Callen will say some closing remarks, and then I will say some closing remarks, and then we will officially close.
All right. Well, I want to keep it short. I don't want to go on a long dramatic speech, but at first I just want to say thank you all so much. Not only to my co-planners, my colleagues in the Spinal CSF Leak Foundation who really taught me so much and sort of reinvigorated my drive for this work, my passion for this work. But thank you to my colleagues. Dr. Beck from the other side of the world doing this later at night. All of my colleagues giving their time to do this on Saturday. I hope shows to all of you patients and patient supporters in the audience that how dedicated this community is to helping, even when we don't have all the answers. I think that the talks today in this conference in general is just a really beautiful example of how far we have come in just a few short years. As frustrating as it could be to have to navigate this system that doesn't have all the resources in place, we are able to do things like this, to come together, to advance the science, to have challenging conversations, and really see each other in ways that I think really tangibly advance this care in so many ways. And so that's it. Thank you so much for your time, your energy, your commitment. Please don't give up. And to any of our patients who are suffering without an answer, please don't give up. To my colleagues who are doing this work for maybe not the appropriate sort of coding reimbursement or a recognition by your hospital. These sorts of things is what make this work worth it. And we're gonna keep pushing forward. And I can't wait until next year when we have even more exciting discoveries and developments to talk about. And so I will hand it over to Jodi to give some last closing remarks. But thank you all from my side, and I look forward to seeing you next year.
Thank you. I feel just as effusive about the participation from the physicians in this conference. A big thanks to Dr. Shavink and Beck and Madhavan for donating your weekend and your time and indulging our great curiosity of all the questions that we've received. I think this field has patients that do a lot of research. They're curious. They want to learn as much as possible. They really want to understand the nitty gritty of the field, and what's happening in the research truly is really fascinating. And we appreciate that you're here and willing to answer those questions and present on aspects of the field that you're deeply involved in. On behalf of the Spinal CSF Leak Foundation, we'd also like to greatly thank Dr. Callen for his curiosity and his desire to have patients involved in these kinds of presentations and partner with us for this unique conference and have discussions that are a little different to ones that would normally be had at a conference. We're going to be finalizing that survey that Dr. Callen referred to and sending it out, and we look forward to everyone's answers to contribute to research as well. And we look forward to seeing you next year. Thank you, everyone, for taking the time to listen, to ask questions, submit your patient videos, and be a part of this collaborative experience. We hope you have a good rest of the weekend.